When you think of tuberculosis, what comes to mind? You probably picture, like, a scene straight out of a Victorian novel,
Right.
right?
Yeah, the classic tragic poet.
Exactly. Some tragic poet in the 1800s coughing delicately into a handkerchief, suffering from what they used to call, consumption.
Which is such an evocative name.
It really is, and it feels like a localized tragedy of the past. I mean, it's a closed chapter in our medical history books. But here is the staggering reality that we found in the source material. TB never went away.
No, not at all.
In fact, it remains one of the world's leading infectious killers. Even now, in the 2020s, it takes well over 1 million lives every single year. It's basically running parallel to COVID-19 as this massive, ongoing global health crisis.
Yeah, and we tend to relegate it to history because in a lot of wealthier nations with really robust public health infrastructure, it operates quietly, in the margins.
Right.
But on a global scale, TB is a devastating, actively evolving pandemic.
And that is the exact mission for today's deep dive into the source material. We aren't just looking at the broad epidemiological numbers. We are putting the biological villain itself under the microscope.
The Mycobacterium tuberculosis bacterium.
Yes, because to understand how this pathogen is, still outsmarting our best pharmacological weapons, you really have to understand how it operates biochemically. So, okay, let's unpack this.
Let's do it.
How does a notoriously sluggish, slow-moving microscopic organism manage to be one of the most successful persistent pathogens in human history?
Well, to fully grasp the biological quirk of this pathogen, we actually have to rewind to the 19th century.
Okay, take us back.
In the 1800s, TB was an absolute terror. It was widely known as the White Plague, and it was killing roughly 1 in 7 people across Europe and the United States.
1 in 7, that's just wild to think about.
It is. And the terrifying part for physicians of that era was the complete lack of a visible culprit. I mean, it didn't act like cholera or smallpox.
Right, those swept through populations with, like, explosive, obvious contagion.
Exactly. TB was this slow, agonizing, wasting disease. So the medical consensus at the time basically blamed miasma.
Oh, the bad air theory.
Right, foul, corrupt air. Or they assumed it was just a hereditary genetic condition because it would slowly wipe out an entire family, but over the course of a decade.
Right. The timeline of the illness was so drawn out that no one could connect the dots between, like, the initial exposure and the fatal outcome years later.
Yeah, the slow progression completely masked its infectious nature from the medical establishment. Though there was a French military physician named Jean-Antoine Villemin.
Okay.
In 1865, he actually proved the contagion empirically.
Really?
He took tissue from humans who had died of TB and inoculated rabbits, and he successfully induced the disease in the animals.
Wow.
It was a brilliant experimental design, but it completely failed to shift the prevailing miasma theory. The establishment demanded a specific visible pathogen, and Villemin just couldn't produce one.
Ah. Enter Robert Koch, which is where the true biological mystery of this organism begins to unravel.
Yeah, March 24, 1882 remains just a monumental date in microbiological history. Robert Koch stood in front of the Berlin Physiological Society and delivered this incredibly rigorous lecture on the etiology of tuberculosis.
Announcing he had finally isolated the organism.
Exactly. And he established Koch's postulates during this work.
Those are the strict criteria still used to prove a specific microbe causes a specific disease, right?
Yep, they are. This presentation decimated the miasma theory and cemented the germ theory of disease. It eventually earned him a Nobel Prize.
But the fascinating part for me is why it took someone of Koch's caliber to find it. I mean, it wasn't merely that early microscopes were underpowered. It was because the TB bacterium is structurally an absolute fortress.
A total fortress.
It completely defied the standard staining and culturing techniques they used for normal bacteria.
Yeah, and that structural fortress defines literally everything about how Mycobacterium tuberculosis interacts with the world. I mean, it is an aerobic, rod-shaped bacterium, but it possesses a highly unique cell envelope.
Yeah.
Beyond the standard plasma membrane and peptidoglycan layer, it synthesizes this incredibly dense, lipid-rich outer barrier. It's made predominantly of mycolic acids.
Mycolic acids.
Yeah, these are extremely long-chain fatty acids that create a highly hydrophobic, waxy layer. And it's linked to an arabatogalactan polymer.
So the bacterium's waxy wall is essentially like wearing a heavy medieval suit of armor. I mean, it makes you incredibly tough to kill, but it forces you to move at a snail's pace.
That is the perfect way to look at it. because the metabolic cost of synthesizing that complex mycolic acid envelope is astronomical.
It takes a lot of energy.
Huge amounts. Like a
Okay.
common bacterium like E. coli can double its population in about 20 minutes under optimal conditions.
Okay, 20 minutes.
Mycobacterium tuberculosis requires 15 to 20 hours just to undergo a single division.
That is so slow.
It is 50 to 60 times slower than E. coli.
Which instinctively sounds like a massive evolutionary disadvantage. You'd assume a pathogen that replicates that slowly would be easily outcompeted or just swept away by the host.
Right.
But that mycolic acid armor grants it near invulnerability in the environment. It resists desiccation. It resists harsh chemical disinfectants.
And crucially for Koch, it resists the standard chemical dyes microbiologists use to visualize pathogens.
Right. So Koch had to invent highly specific staining protocols just to make it visible.
Yeah, microbiologists classify it as acid-fast.
Mm.
In the standard Seal-Nielsen stain, you use heat to basically force a red dye called carbolfusin through that waxy envelope.
And then you wash it.
Yeah, you subsequently wash the slide with a harsh acid-alcohol mixture. Standard bacteria are immediately stripped of the dye.
But the TB bacterium holds onto it.
Exactly. The acid cannot penetrate the hydrophobic wax to bleach it. But while this is a fascinating diagnostic quirk, clinically, this slow, armored growth caused an absolute nightmare for patient care.
Oh, I bet. Because if a patient presents with chronic coughing and weight loss, and you need to confirm active pulmonary TB, you have to culture their sputum in a laboratory.
And because of that 15 to 20-hour doubling time, culturing it on the classic Lowenstein-Jensen medium historically took 6 to 8 weeks to yield a visible colony.
6 to 8 weeks. Imagine the clinical reality of waiting up to 2 months for a confirmed diagnosis.
It was awful. During that entire window, the patient is either deteriorating without targeted therapy, they're potentially transmitting the pathogen to their community.
Or they're being subjected to broad-spectrum empiric antibiotics that do absolutely nothing to penetrate that mycolic acid wall.
Right. 2 months of flying completely blind.
Thankfully, modern medicine has bypassed this bottleneck, right? We aren't waiting 8 weeks for a culture anymore.
No, thankfully. Modern molecular diagnostics have completely revolutionized this specific bottleneck. The WHO actually endorses the GenExpert NTBRIF assay.
GenExpert, yeah.
It utilizes highly automated nested polymerase chain reaction, or PCR technology. So instead of waiting for the bacteria to slowly replicate, the assay amplifies the specific genomic DNA of the pathogen directly from the raw sputum sample.
Which compresses a terrifying 2-month wait into, a 2-hour afternoon turnaround.
Yep, 2 hours, while simultaneously detecting genetic mutations that confer drug resistance.
That is a phenomenal technological leap. But let's look at the biology of what happens when that armored bug actually gets inside a host. Because the mycolic acid layer doesn't just protect it from lab dyes or drying out, it actively subverts our innate immune system.
It really does.
And this leads to what might be the strangest cellular standoff in all of human biology.
Yeah, the initial infection involves a microscopic battle of attrition. When a patient with active pulmonary TB coughs, they expel aerosolized droplet nuclei containing the bacilli.
Right, and you inhale these droplets.
And their microscopic size allows them to bypass the upper respiratory defenses and travel deep into the alveoli in your lungs.
Where the immune system meets them.
Exactly. The immune system's immediate response is to deploy resident alveolar macrophages to engulf the foreign invaders.
Right, the macrophages phagocytose the bacteria. They essentially swallow them, they pull them into an internal cellular compartment called the phagosome.
Correct.
And standard operating procedure for a macrophage is to then fuse that phagosome with a lysosome, right? Which is just packed with degradative enzymes and highly reactive oxygen species to obliterate the pathogen.
That's what's supposed to happen. But Mycobacterium tuberculosis actively halts that process.
How does it do that?
It secretes specific virulence factors, including this complex lipid called liporubinomannan.
Okay.
And that directly interferes with the host cell's intracellular trafficking signals. It essentially paralyzes the macrophage's internal machinery, blocking the fusion of the lysosome altogether.
So the hostile acidic environment never materializes.
Never happens. The TB bacterium not only survives, but it begins to slowly replicate inside the phagosome of the very immune cell deployed to destroy it.
Oh man, the call is coming from inside the house. The pathogen is literally using the immune system's heavy infantry as a mobile breeding ground. So if the primary strategy completely fails, what does the immune system do next?
It initiates a complex secondary containment protocol. If it can't eradicate the pathogen, it physically walls it off.
It builds a wall.
Yeah. The infected macrophages secrete chemokines to recruit a massive influx of T lymphocytes, B cells, and additional macrophages to the site of infection. And these cells aggregate to form a highly structured spherical barricade known as a granuloma.
Okay, a granuloma.
In pulmonary TB, this initial anatomical lesion is referred to as a gun-bone focus. And at the center of this cellular prison, the macrophages often undergo a specific type of programmed cell death.
Creating that necrotic core.
Right, it creates a hypoxic, acidic core of caseous necrosis. It's this dense, cheese-like substance.
And this is where the dynamic gets incredibly precarious, according to the sources, because this granuloma doesn't necessarily achieve sterility, right? It doesn't kill all the TB bacilli inside.
It doesn't.
It forces them into a state of metabolic dormancy. They essentially hibernate within that necrotic core. And this is the physiological basis of latent TB infection, or LTBI.
Exactly.
You harbored the live bacteria in your lung tissue, but you are asymptomatic, non-infectious, and completely unaware.
The immune system essentially forces a tactical stalemate.
But looking at the global numbers, this is what absolutely stopped me in my tracks. The WHO estimates that roughly 25% of the global population carries this latent TB infection.
Yeah, about 2 billion people.
2 billion. Wait, if a quarter of the world's population is walking around harboring a dormant, highly infectious lung pathogen, why aren't we seeing constant, massive outbreaks everywhere?
Yeah.
Does the body's prison actually work most of the time?
What's fascinating here is that the immune system's structural containment holds beautifully for the vast majority of hosts.
Really?
Yeah, of that enormous global population with latent TB, only about 5 to 10% will ever progress to active symptomatic disease in their lifetime.
Okay, that's a relief.
But the granuloma is not a static wall, right? It is a highly dynamic structure. It requires constant, active immunological surveillance and maintenance. So as long as the host's cellular immunity remains robust, the bacilli stay contained.
So what causes that surveillance to fail?
Any systemic event that compromises cellular immunity.
Yeah.
HIV co-infection is the most devastating trigger, leading to a massive, lethal syndemic between the two pathogens.
Right, because HIV wipes out T cells.
Exactly.
Right.
But also severe malnutrition, poorly controlled diabetes, even just the natural senescence of the immune system during aging, or the administration of immunosuppressive pharmacotherapy.
Right.
When the immune system falters, the cellular architecture of the granuloma collapses, the caseous core liquefies, the dormant bacilli resuscitate and rapidly multiply.
And the patient transitions into active, highly contagious pulmonary TB.
Precisely.
Which brings us to a mind-bending, almost accidental revelation in modern pharmacology that the sources highlight. Because we just established that the host actively maintains these granulomas to keep TB dormant.
Right.
But what happens if modern medicine, attempting to cure a completely unrelated pathology, accidentally knocks down those prison walls?
Yeah, it serves as a stark reminder of the profound interconnectivity of human immunology. In the late 1990s, rheumatologists and gastroenterologists began deploying a revolutionary new class of biologic therapeutics.
These were the TNF inhibitors, right? Like infliximab.
Exactly. These monoclonal antibodies were designed to treat severe autoimmune and inflammatory conditions, things like rheumatoid arthritis and Crohn's disease.
Because in those specific conditions, the host's immune system is pathologically hyperactive. It's driving destructive inflammation in the joints or the intestinal mucosa.
Right. And tumor necrosis factor alpha, or TNF, is a highly potent cytokine that drives much of that inflammatory cascade.
Okay, so you block it.
Right. Administering a drug that neutralizes TNF profoundly downregulates the inflammation, which offered miraculous clinical improvement for arthritis patients.
But there was a catch.
A terrifying adverse event signal emerged shortly after widespread clinical adoption. Patients with no recent exposure to tuberculosis, living in low-burden countries, were suddenly presenting with explosive, fulminant cases of active TB.
And it wasn't just localized to the lungs, right? We have to clarify a major misconception here. TB is not exclusively a pulmonary disease.
No, definitely not.
When it reactivates aggressively, it can disseminate systemically. Extrapulmonary TB can destroy the vertebral column, which is known as Pott's disease, or invade the central nervous system, causing highly lethal TB meningitis.
Yeah, and the rheumatology community was entirely blindsided by this rapid dissemination. I mean, why were patients being treated for joint pain suddenly presenting with spinal tuberculosis?
It seems so disconnected.
But the immunological mechanism eventually crystallized. TNF-alpha is not just an inflammatory mediator, it is the critical chemical signal required to maintain the structural architecture of the granuloma.
Oh, wow. So the exact same molecule driving the arthritis is acting as the mortar for the TB prison.
Yeah. Exactly. TNF regulates the activation state of the macrophages and prevents the granuloma from liquefying. So, by therapeutically neutralizing TNF to alleviate joint inflammation, clinicians were inadvertently dissolving the granulomas in the lungs.
Letting the bacteria out.
Yeah, dormant bacilli that had been successfully contained by the host for decades suddenly resuscitated, multiplied, and disseminated systemically.
So the basic biology of this one lung pathogen ended up completely rewriting the rule book for autoimmune doctors treating arthritis. That's wild.
It really is.
Now, undergoing treatment for rheumatoid arthritis requires mandatory prior screening for a latent lung infection you might have acquired 20 years ago.
Yes, standard clinical guidelines globally now mandate screening via a tuberculin skin test or an interferon gamma release assay, an IRGRA, prior to initiating any anti-TNF therapy.
And if they test positive.
If the assay indicates latent infection, the patient must complete a prophylactic course of antimicrobial therapy to eradicate the dormant bacilli before the biologic drug can be safely administered.
That makes sense.
Which, importantly, addresses another common source of public panic. A positive IGRA blood test implies you harbor the latent, non-contagious infection.
Yeah.
It does not mean you have active disease requiring immediate respiratory isolation.
Right. So what does this all mean for treatment? If that latent infection reactivates or if a patient acquires a primary active infection, we have to eradicate the organism.
Yes.
But how do you chemically poison a pathogen wrapped in a highly impenetrable waxy envelope that replicates slower than almost any other bacteria?
You deploy a highly aggressive, deeply prolonged multi-drug regimen.
Okay.
The standard pharmacological approach is DOTS, directly observed treatment, short course. The intensive phase utilizes 4 concurrent, potent antimicrobials, commonly referred to by the acronym RIPE.
RIPE.
Right. Isoniazid, rifampin, pyrazinamide, and ethambutol.
Which, calling a 6 to 9 month continuous antibiotic regimen a short course, feels like a dark joke.
It really does. But the extreme duration is a direct consequence of the pathogen's phenotype. Antimicrobials are generally most efficacious against bacteria that are actively metabolizing and replicating.
Right, they attack active processes.
Exactly. Isoniazid, for example, specifically inhibits the synthesis of those crucial mycolic acids. But it only works when the bacterium is actively trying to build a new cell wall. Rifampin inhibits bacterial RNA polymerase, halting transcription.
So, if the TB bug only divides every 15 to 20 hours and frequently shifts into subpopulations of metabolically dormant persister cells within the hypoxic granuloma, the drugs simply don't have a target to attack.
Precisely. If we connect this to the bigger picture, you have to maintain suppressive pharmacological concentrations of these 4 drugs in the patient's system for the better part of a year.
Just to catch them.
Yeah, to ensure you eradicate every single subpopulation of bacilli as they sporadically exit dormancy and become vulnerable.
It's exactly like trying to poison a hostile animal. I mean, if you're targeting a fast-moving cheetah with a high metabolic rate, the poison works immediately upon ingestion.
Right.
But if you are targeting a hibernating bear, taking one shallow breath a minute, you have to keep flooding its environment with poison for months, just hoping to catch it during the rare seconds it briefly wakes up and metabolizes the drug.
That hibernating bear dynamic is the primary driver of the most terrifying crisis in global TB management today.
Antimicrobial resistance.
Exactly. Consider the realities of human behavior and drug toxicity. A patient is prescribed a rigorous regimen of 4 hepatotoxic drugs for 9 months.
That's rough on the liver.
By month 2, the active replication is usually suppressed. The clinical symptoms resolve. The cough disappears. The fever breaks. The weight loss halts.
So the patient understandably assumes they're cured.
Right.
And because the RIPE drugs have miserable side effects like nausea and liver toxicity, they just abandon the regimen.
But they haven't achieved sterilizing immunity. They have only eradicated the most metabolically active, susceptible bacilli.
The easy targets.
Right. The subpopulations remaining in the lung tissue are the most resilient, slow-growing persisters, which now face sublethal concentrations of the drug.
Which is a recipe for resistance.
Exactly. Mycobacterium tuberculosis doesn't generally acquire resistance through horizontal gene transfer like E. coli. It relies on spontaneous chromosomal point mutations.
Okay, like what?
For instance, a mutation in the KG gene confers resistance to isoniazid, while mutations in the RPAB gene block rifampin. When the patient stops taking the drugs, they are actively selecting for these mutated strains to repopulate the lungs.
We are essentially running an evolutionary training camp inside the patient's lungs, actively breeding invincible strains.
Patient non-adherence is the direct mechanistic engine driving multi-drug-resistant TB, or MDR-TB.
Wow.
By definition, MDR-TB strains have evolved resistance to both isoniazid and rifampin, which are the two most powerful bactericidal weapons in our arsenal.
And if they keep mutating?
If the selective pressure continues, it progresses to XDR-TB, extensively drug-resistant TB. And that strain also resists the crucial second-line fluoroquinolones and injectable aminoglycosides.
And when you hit MDR or XDR-TB, that 6 to 9 month marathon gets vastly worse, doesn't it?
So much worse.
The sources mentioned the treatment regimens can stretch to 18 to 24 months, utilizing highly toxic second-line drugs that carry risks of permanent hearing loss, peripheral neuropathy, and even severe psychiatric side effects.
Yeah, it is a phenomenal failure of public health infrastructure, which is why resistant TB is flagged by the WHO as a critical global security threat.
Well, if treatment is this biologically fraught and actively risks breeding untreatable superbugs, the obvious solution is prevention.
Right, vaccination.
We need a vaccine to preempt the infection. But historically, our attempts to develop prophylactic measures against TB have resulted in catastrophic failure.
The history of TB prophylaxis is incredibly dark. Let's return to Robert Koch for a second.
Oh.
8 years after his triumphant discovery of the bacterium, he stood before an international medical congress in 1890 and prematurely announced a cure. He called it tuberculin, and it was a glycerin extract derived from boiled cultures of the TB bacilli.
He had just solved the etiology of the disease, so the global medical community inherently trusted him.
They absolutely did. Desperate patients flocked to Berlin. But Koch had bypassed rigorous clinical trials. Tuberculin was not a curative agent. It was highly immunogenic.
Meaning it triggered an immune response.
A massive one. When injected into patients with active TB, it triggered a systemic delayed type hypersensitivity reaction. It exacerbated the inflammation, accelerated the tissue necrosis, and directly caused the death of several patients.
That's horrifying.
It devastated his reputation. Though, ironically, a purified derivative of that exact tuberculin extract is what we safely inject under the skin today for the MAN2 test.
Right, the TB skin test.
Yeah, purely as a diagnostic tool to check for latent cellular immunity.
Okay, so the tuberculin cure was a lethal misstep. What about the actual vaccine?
The vaccine originated with two French scientists, Albert Calment and Camille Guérin, beginning in 1908. They acquired a virulent strain of Mycobacterium bovis.
Which is the closely related pathogen that causes tuberculosis in cattle, right?
Exactly. They theorized that by subculturing the bacteria repeatedly over years, they could attenuate its virulence while maintaining its immunogenicity.
So weaken it, but keep it recognizable to the immune system.
Right. And over 13 years and 230 passages in vitro, the bacterium lost key genomic virulence regions, specifically a segment called RD1.
Okay.
This weakened strain became the BCG vaccine, and it was first administered to a human infant in 1921.
But the deployment of BCG led to one of the most horrifying tragedies in public health history, right? The Lübeck disaster in 1930.
Yeah, in Lübeck, Germany, a catastrophic manufacturing protocol failure occurred. A batch of the attenuated BCG vaccine was cultured in the exact same incubator as a fully virulent strain of human TB,
Oh my.
resulting in massive cross-contamination. This lethal batch was administered orally to roughly 240 neonates.
And the outcome?
Approximately 72 infants died of disseminated tuberculosis, directly caused by the contaminated vaccine.
Wait, a vaccine killed 72 babies, and public health officials still kept it around to become the most used vaccine in history? How did they regain that trust?
It was a massive crisis. But the subsequent criminal investigations and autopsies proved that the underlying scientific principle of attenuation was entirely sound.
It was just human error?
Exactly. The tragic fatalities were not caused by the BCG reverting to virulence. They were caused by gross negligence in laboratory segregation. This disaster actually forced the immediate implementation of rigorous, highly standardized good manufacturing practices.
Which we still use today.
Right. That regulatory oversight for vaccine production forms the foundation of global pharmaceutical safety today.
But even with the manufacturing safety protocols completely overhauled, we are still relying on a deeply flawed tool.
We are. BCG is an immunological compromise. When administered intradermally to infants, it is highly efficacious at preventing the severe, disseminated forms of childhood TB.
Like miliary TB and TB meningitis.
Right. And that systemic protection is why it remains mandated in high-burden countries. However, its primary failure lies in preventing adult pulmonary TB.
Which is the highly contagious respiratory form that actually drives the global pandemic.
Exactly.
Right, the clinical trial data on BCG efficacy for adult pulmonary TB swings wildly, doesn't it? From like 80% effectiveness in some demographics down to literally 0% in others.
Yeah, and whether the failure is due to waning cellular immunity over decades, or genomic divergence of the vaccine substrains, or even pre-existing immunity masking the vaccine's effect due to environmental exposure to non-tuberculous mycobacteria, it remains hotly debated.
There are a lot of variables.
There are. The mucosal immunity in the lungs simply fails to prevent initial infection. We are utilizing a century-old biological compromise. Developing a highly efficacious adult pulmonary vaccine remains the holy grail of modern immunology.
Man, we have covered a tremendous amount of incredibly complex biology today. We started with Koch, identifying a sluggish mycolic acid armored fortress that fundamentally defies standard microbiology.
Truly unique.
We examine how that slow metabolism necessitates a brutal 6 to 9 month pharmacological marathon, which, as we saw, directly drives the evolution of XDR-TB when adherence fails.
Yep.
We explored the astonishing cellular hijacking within the phagosome, leading to granuloma formation and a latent infection that sits dormant in a quarter of the global population, only to be accidentally unleashed by modern anti-TNF therapies.
It's all connected.
And finally, we navigated the tragic, complicated history of our primary defense, the BCG vaccine.
It is a masterclass in pathogenic endurance.
It truly is an evolutionary marvel. Thank you for walking us through the biochemical mechanisms behind this ancient threat.
You know, before we close, this actually raises an important question regarding the fundamental biology we've been discussing.
Oh, what's that?
We've been using the term Mycobacterium tuberculosis as if it is a single isolated species. But genomic sequencing reveals a profound taxonomic mystery in the source material.
I love a taxonomic mystery.
The pathogen is actually part of a highly constrained evolutionary lineage called the Mycobacterium tuberculosis complex, or MTBC.
Okay, the MTBC.
This includes M. tuberculosis in humans, M. bovis in cattle, M. micruti in rodents, and even M. pitipedii, which specifically adapts to infect seals and sea lions.
Wait, really? Seals?
Yes, seals. And here is the biological paradox. At the genomic DNA level, every member of the MTBC is over 99.9% identical.
Wow.
They exhibit less genetic diversity than many bacterial subspecies, yet despite this near-perfect genetic cloning, their real-world phenotypic behavior is vastly different.
That doesn't make sense.
Right. It allows them to precisely target and adapt to entirely distinct mammalian immune systems, from a human lung to a bovine respiratory tract to a seal swimming in the ocean.
That's incredible.
It challenges us to ask, if organisms are 99.9% identical genetically, but their real-world identities and host ranges are that vastly divergent, is our classical textbook definition of a biological species fundamentally broken?
That is an incredible thought to leave on. Not just a persistent pathogen, but a genomic shapeshifter that challenges our basic scientific classifications. Thank you for joining us on this deep dive into the source material. Stay curious, keep questioning the mechanics of the world around you, and we'll catch you on the next one.